Hello. Tonight I'm going to answer a question that I received in the Canadian Implant Dentistry Network Facebook group. If you're not in that group, I believe Mark Bashar runs it. It's a great group, lots of good discussions. And the question from Dr. Gupta is, Dr. Bullard, could you kindly share what experiences or thinking led to using titanium substructures in all final arches? That's a great question, and it's a personal decision that I've made uh, to do that in my office. And the reason is the short answer is I want the highest quality for my patients and I want the least amount of complications for my practice. So, what's led me there? I think that a one-to-one mill is important. It's critical for me in the full arch process. I believe that I mill my provisionals because I think that printing them isn't as accurate as a lot of doctors believe that it is. I think any of these processes, I think in the right conditions, in the right hands, uh, can be and are successful. I can tell you, I've seen plenty of arches that don't fit and aren't as accurate as they could be or should be. I've been in doctors' offices that had performed surgeries trying to place the provisional that's printed and it doesn't fit. There's some variables in there. How's your machine working? How's everything calibrated? Is your resin mixed? How old is your resin? So I think it's important to verify your processes. I think if you're getting squeaky screws or having to force things, it probably doesn't fit. It's going to build stress in your restorations or your screws. Um, Also, zirconia. I think there's some inaccuracies in zirconia that I think a lot of doctors don't realize or focus on. Can you mill a directive fixture full arch and it fit? Yes, you can. Do I believe that if you give 1,000 doctors an oven and they go out shopping for zirconia, buying it from different sources, using different parameters in their ovens aren't calibrated, or is there a possibility that there are arches out that don't fit? Absolutely. I've had doctors mill arches, center them, and send them to me for me to try it on a jig from a one-to-one milled restoration, and it didn't fit. From the same doctor, a well-known doctor, sent me a 3D prints of the same STL file. They didn't fit. None of the arches fit the other jig. So it's out there. There's some ill-fitting restorations, and I think we owe it to our patients to at least study that and understand and not put those inaccuracies. I mean, if you got a squeaky screw, I know it's hard. If you've spent all the time on the case, you just want to put it in and tell the patient, adjust the occlusion and feel good about yourself. But the reality is, if it doesn't fit, it's going to fail. The screw is going to break, a tie base is going to come out, the zirconia is going to fracture in half, and all these things happen. I've seen all of them in my office. And can you hone your skills in and your manufacturing down where most of the time things are perfect? Yes. Are there doctors out there doing it? I think so. But are there going to be some problems along the way? I also believe that is true. So for me, in my office, I want to have the least amount of complications, because every time there's a complication, I'm dealing with it. I'm dealing with chair time. It's putting the patient out. We're having to remake things, try to figure out what the problem was, seeing if we can salvage the restoration or if we need to remake the restoration. And it's just a major time suck. And when I'm by something, I want something quality, whatever it is. I want it to look good in most cases. Pretty much everything. I want it to look good as it should, and I want it to last. I want it to be durable. So for me, a one-to-one milled titanium substructure is an absolute. I use photogrammetry. I use ICAM. I believe ICAM is incredibly accurate. It's for surgery. I do use the Bullard alignment healer if you want to check that out. That's a cool little creation that I've made, but along with Austin Heath. But it's when I bring that information into my cams or to my design software, and then I mill from that. Every time I put an arch in with a titanium substructure, my 19.306 screws spin, 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 dead stop. So that means I've got a flush connection to the MUA, and the base of the screw is flush to its seat. and it's consistent every time they go in. It's that way. So I know that I'm not building stress into my screws in that way. Also, any inaccuracy of the centering of the zirconia can be taken up. It's either just going to cause can be taken up in cement gap, or it's going to be an occlusal adjustment. That being said, I did mill and center a monolithic arch the other day just as an experiment. Got great results. It was a 3-hour center zirconia from Zubler in the Memvoint oven, and it was great. Have I milled? I've centered arches in the past where they didn't fit, and I don't want to get to delivery day where an arch has been characterized and everything, it's ready to go, and it doesn't fit, or down the road it breaks. So those are my thoughts. I know some of the doctors talked about space. I think the space that you need is minimal. I mean, because you have in Blender, you have the option of designing your bar out of your STL or cutting it out of it. I know we use custom titanium abutments with a crown all the time. I don't think the thickness, you don't need some great thickness of zirconia when it's cemented to a titanium bar, and you have leeway too on the thickness of the bar. But again, when we're doing full arch, I mean, most of the time we're the ones doing the surgery and making that space in the beginning. So I know sometimes it can get limited, but in the majority of cases, FP2, FP3 cases, I don't think it would be a problem. I even see guys doing it for FP1 sometimes. So those are my thoughts. That's why I use zirconia in all of my arches, because titanium substructures in all of my arches, because it is strong, because it is accurate, and because I want the least amount of problems for my patients as possible. Another point, I'm dealing with these complications when they happen, but my patients also move away, and so I want my patients out in the world to have as few problems as possible, and I don't want them going to other doctors with busted restorations that I know I could have done better, I could have made more accurate and more strong. So those are my thoughts. I hope you find that helpful, and if you have any questions, let me know. Thanks.